The second issue is whether we are supposed to do mechanical valve replacement or bioprosthetic valve replacement. Again, this is not truly an issue among the Philippine cardiologists because you seldom ask for it. You seldom for those of you who just recently came from training, how many times have you seen a service patient being transplanted with a bioprosthetic valve? I cannot remember our ever doing it. There was a time, as a part of a marketing strategy, one of the bioprosthetic valve distributors was actually marketing the bioprosthetics much cheaper than the metallic prosthetics. These are the metallic prosthetics: the St. Jude's, the Carbomedics, the Sorin Bicarbon, the Edwards Mira. All of these are available in the Philippines and are being used in the Philippines. So the first slides are all by leaflet. They're usually preferred because they have a lower profile. Especially in the mitral position, there is less risk of the valves getting caught in the chordae, which are supposed to be preserved. These are mono leaflets: the Monostrat, the Sorin, the Medtronic, and the Omnicarbon. The only one that is available here in the Philippines right now is Medtronic, and we haven't been implanting Medtronics for quite some time. So for most of the valve replacements that we have done with metallic prosthetics, what we have been using are the bileaflet valves. These are the bioprosthetic valves by Medtronic. This is a whole aortic root which can be tailored. So it's we call it a freestyle Medtronic aortic valve. These are all from PIGS valves. We are actually currently studying the possibility of resuming the PHC bioprosthetic project. We were able to implant something like 87 valves from 1977 to 1985. By the time I was doing my own training in the early 90s, we were just explanting some of these valves. Now, those of you who attend or even ask about bioprosthetic valves in distributors when you attend conventions, they will tell you that they are now talking about 15 to 20 years lifespan for the bioprosthetics. The reason why we did not want to use bioprosthetics before is because the lifespan used to be something like 10 years. So after 10 years, which is also the lifespan of a mitral valve, of a valve repair, after 10 years, you're expected to come back and replace it. Now, bioprosthetics have lifespans that are supposed to be extended. Parang lifetime guarantee pa nga yung sinasabi nila. Hindi nila masabing talagang this is guaranteed to last for a lifetime, but that is essentially their marketing ploy right now. They're talking about guaranteed 15 to 20 years. This is another set of bioprosthetic valves, the St. Jude's, Epic, Toronto, and Toronto Root. So when do we decide what valve to use? The patient age is one of the major factors. Very, very young, very old bioprosthetic. So you don't need to go back for the very old, for the young, because you're still really going to go back when they grow. At the very least, you're not going to give a lot of medications, anticoagulant for these patients. Patient age for childbearing women. Those who are in the childbearing age, who have not had any children, patients who undergo mitral valve replacement with metallic valves do come back to us after pregnancy to die in the center. It is usually too late for us to save them. So they're going to go to a center where they can deliver. The baby is out, they're brought to the heart center, and we have a very, very short window within which we can save these patients. A number of these patients die on us. So now the recommendation is really, if you have a metallic prosthetic valve, although there are manipulations you can do, you know the teratogenic effect of Coumadin is going to be in the first trimester, so you can still probably remove it afterwards. Even if you're able to save the baby, you are going to have a lot of problems managing the mother. So, patient age, childbearing, wants to have children, bioprosthetic should be an option. Even if they have to go back, they can at least have their children. Pathologic process is important. If it is rheumatic, we used to repair a lot of rheumatic valves. But these patients come back earlier than usual. So now patients with calcifications, especially in the leaflet margin, we do not really repair anymore. The valve anatomy, the presence of atrial fibrillation, sometimes this is one of the big considerations when we need to choose between a metallic or a bioprosthetic. When the patient has atrial fibrillation, the thinking is, this patient is going to anticoagulate anyway. Why put a bioprosthetic? We have not resolved that issue on whether we can do away with giving Coumadin in a patient with bioprosthetic and atrial fibrillation. So the trend still is to replace with a metallic if a patient is going to anticoagulate. Bear in mind, when you replace, whether it is bioprosthetic, and especially if it is metallic, you are replacing one disease with another disease. Hindi siya talaga disease. But can you imagine this patient needing to come back to you every 3 months? Yung ibang recommendations, every 2 months to have your prothrombin time. Hindi ano yun eh, hindi simple yun para sa pasyente. Yung pasyenteng nasa probinsya, mahirap magbalik-balik, mahirap mag-depend doon sa prothrombin time in the provinces. When I do valve surgery, I will try to compare the prothrombin time determination in their clinic in the province and prothrombin time at the same period in the heart center. And there is usually a marked discrepancy. So importante na matatansya nyo kung kailan ka mag-a-adjust ng Coumadin, especially in metallic prosthetic valves. Compliance with anticoagulation is very important, especially for our, unfortunately, poorer patients. Unfortunately, these are also the patients that have severe rheumatic heart valve disease that require metallic prosthetic replacements. Anticipated durability of the prosthesis. As I was saying, right now, bioprosthetics are being marketed as nearly lifetime longevity. And of course, the comfort level of the patient, the surgeon, and the cardiologist. Bakit of course yung comfort level? Kasi kuminsan, hindi pala kuminsan, malimit. What determines what kind of procedure we're going to do is really the doctor, the cardiologist, or the surgeon. Not necessarily because it is guideline-based.